Welcome back to Decode Healthcare with Harshal for part 50 of our 100-part ICD-10 CM Guidelines series. Guys, we have officially hit the halfway mark. For today's explainer, we're taking on a massive and highly scrutinized topic, Section IC10B. We're going to completely master acute respiratory failure, decode the principal diagnosis selection rules, conquer those tricky acute on chronic combination codes, and learn exactly how to survive intense clinical validation audits. Our goal today is 100% accuracy based strictly on the official guidelines. Let's dive in. Here's our roadmap for today. First, the ultimate authority. Second, principal diagnosis. Third, secondary diagnosis. Fourth, dual acute conditions. And finally, acute on chronic. Okay, let's jump straight into Section 1, the ultimate authority, CMS guidelines. Now, when you're coding for high-severity conditions like respiratory failure, you might be tempted to just lean on textbooks, like Buck's Step by Step. But here's the deal. The CMS guidelines are the absolute law. As this quote lays out, chapter-specific coding guidelines that provide sequencing direction take precedence. That means if CMS has a specific rule for a diagnosis, it completely overrides any textbook, period. It dictates exactly how that claim must be sequenced. So our exact coordinate today is section IC10.B. This is the specific CMS guideline that gives us the sequencing rules for acute respiratory failure. When you're dealing with a respiratory failure claim, especially if an auditor is breathing down your neck trying to downgrade your code, this section is your ultimate shield. By strictly complying with it, you make your coding absolutely bulletproof. Right, moving on to Section 2. Principal diagnosis selection. In the hospital inpatient setting, the principal diagnosis is everything. It's the most powerful position on the claim, and it heavily impacts reimbursement and severity of illness. So how does respiratory failure earn that coveted #1 spot? Well, the guidelines give us a very clear 3-step checklist. Step 1, the condition must be established after study. Step 2, it must be chiefly responsible for occasioning the admission. And Step 3, the selection has to be supported by the alphabetic index in the tabular list. If the diagnostic workup confirms respiratory failure brought them in, it belongs in that principal slot. When those criteria are met, the specific subcategory we utilize is J96.0 for acute respiratory failure. Think of it like a giant scale in your mind. On one side, you've got J96.00 for acute respiratory failure, and on the other side, a localized infection like J18.9 for pneumonia. If the documentation proves the respiratory failure itself fundamentally drove that admission, boom, the scale tips. J96.00 drops right into that #1 principal slot on the billing form. Chiefly responsible for admission equals principal diagnosis. But, it's medical coding. So, of course, there are caveats. Even if J96.0 is established as the chief reason for admission, certain chapter-specific guidelines will immediately bump it out of that principal spot. We're talking about obstetrics, poisoning, HIV, or newborn guidelines. Those chapters pull rank. They have sequencing directions that take absolute precedence over the respiratory system guidelines, no matter what. Which brings us to Section 3, when it becomes secondary. So we know how it leads a claim, but when does it drop down to a secondary line item? Well, it becomes a secondary diagnosis if it develops after admission. Say a patient comes in for a routine surgery, but on day 2, they go into respiratory failure. Because it happened post-admission, it cannot be principal. The other reason, it was present on admission, but it simply doesn't meet the definition of principal diagnosis, meaning something else was chiefly responsible for getting that patient into the hospital. Let's tackle Section 4, sequencing dual acute conditions. Imagine a patient presents with acute respiratory failure and another acute condition, like a severe myocardial infarction or aspiration pneumonia. Both are severe, right? Both are acute. This is usually the trickiest scenario coders face, but the guidelines are clear. The principal diagnosis won't be the same every time. Depending on the clinical emphasis of the admission and the actual therapy provided, either condition can technically lead the claim. Check out this direct quote from Section 2C that proves it. If both are equally responsible for occasioning the admission to the hospital and there are no chapter-specific sequencing rules, either may be sequenced first. This is a huge deal for defending your codes in an audit. If the documentation proves both acute conditions were equally responsible for the admission, it's a tie. And in a tie without chapter-specific overrides, you have the ultimate authority to sequence either one first. Okay, final piece of the puzzle, Section 5. Acute on chronic failure. What happens when a patient has an acute breakdown of an underlying chronic respiratory state, like a sudden COPD exacerbation? To handle this efficiently, ICD-10-CM uses a combination code. It's exactly what it sounds like: a single code used to classify two diagnoses, or a diagnosis with an associated secondary process. It completely saves us from assigning two separate codes when one highly specific code tells the entire clinical story. And that brings us to subcategory J96.2 for acute and chronic respiratory failure. Picture two separate clinical icons, one for acute failure, one for chronic, and they just merge together into a single glowing code box, J96.20. Whenever you see an acute breakdown of a chronic respiratory state in the chart, you go straight to a combination code from category J96.2-. Now, a quick reminder on the general rule for acute and chronic conditions. Usually, if the same condition is both acute and chronic, and they have separate sub-entries at the same indentation level in the index, you code both and sequence the acute one first. But remember the rule we just talked about. Because the classification provides a single combination code, J96.2-, that clearly identifies both the acute and chronic elements, you assign that single code instead. It's all about capturing the absolute highest level of specificity. So, to wrap this all up, what happens if the documentation is murky, or you can't tell if two acute conditions are equally responsible? Your next step is your ultimate coder defense: query the provider. Listen, because this is a high-severity claim, payers are going to relentlessly target it in MSDRG audits. They're going to look at arterial blood gas values like a PO2 less than 60 or a PCO2 greater than 50, and they will try their hardest to downgrade your claim to simple hypoxia. Your absolute best shield against that downgrade is strict compliance with section IC10.B and airtight documentation. All right, thank you so much for joining me for part 50 of Decode Healthcare with Harshal. Please make sure to subscribe, hit that like button, and share this explainer with your revenue cycle teams. You definitely won't want to miss part 51, where we are moving into chapter 11 to conquer GI bleeding, ulcers, and alcohol-induced hepatic conditions. Until then, ask yourself, is your facility's documentation actually strong enough to survive an audit downgrade?